Thank you, Professor Ish. As far as the drug-induced liver injury is concerned, we call it the DILI. The drug-induced injury is very common, and I would say every medicine or the drug can cause hepatotoxicity. So it is very important whenever we are taking any drug or any medicine, the doctor has to take precautions that whether it is hepatotoxic or not, and due precaution has to be taken from the very beginning so as to prevent the drug-induced liver injury. So as far as the medicine and drug is concerned, nowadays there is an increasing use of the herbals for the point of the health also. And for example, in COVID-19, they have been taken imbibed basically to enhance the immunity. So there was a concept whenever there is a immunity is low and there are the comorbid situations like diabetes mellitus or organ failure, the immunity of the body is low and COVID basically or coronavirus infect these people who are having the low immunity. That is a general perception in the general population. And that is something that the herbals, there are several herbal preparations have come in the market, you know, even from the Patanjali also and many others also, that if you take this herbal or the combination of the herbals, that would enhance the immunity, so that would fight against the COVID-19 and may harm less. But it is not true, because many of these herbs, that is the case for today, that we are presenting as a herbal induced liver injury because of the Giloy. The Giloy, you know, it is a common name in India, and there is an easy access also, and it can be taken in various form, starting from the stems to the leaves and other things also. And today's clinical grand round will be presented by our young, brilliant hepatologist, Dr. Akash Roy. Dr. Akash Roy has done his DM from Department of the Hepatology, PGIMER, Chandigarh. And he is a very hard-working person, very brilliant, I would say, and at the same time, he is producing many papers and the research also. May I request now Dr. Akash to present this clinical grand round.
Thank you, sir, and good morning to all faculty members, dear colleagues, friends, and residents, and everybody else assembled. As we take a look on herbals induced liver injury with specific reference to cases that we noted over the past year. So, drug-induced liver injury overall is an uncommon entity, but being uncommon, it is potentially lethal. The global annual crude incidence of around 2.5 to 14 cases per lakh population, a subtype of drug-induced liver injury constitutes of herbals and dietary supplements. What are these? These can be anything ranging from vitamins, minerals, natural herbs, and herbal preparation. Global data suggests that around 16% of overall cases of drug-induced liver injury belong to these group, and emerging data from India also suggests that around 10 to 14% of all cases belong to HILI. The problem with this group of drugs is that these are promoted as naturals, but all that's natural is not safe. Just as mushrooms are natural, but all mushrooms are not safe. And the safety data with these products are chiefly regulated by three global bottlenecks, which is applicable worldwide, of poor regulation, poor monitoring, contamination, and adulteration. As every story has a prelude, these cases have a prelude too. As the COVID-19 pandemic raged, we had an enormous increase in the use of herbal supplements. Global data from respondents, on the left-hand side, you see a response data from 3,000 respondents, out of which 60% of them resorted to use of these products primarily for improving immunity. Even from Indian data that says that around 60 to 65% of the population of around 10,000 respondents resorted to some sort of herbal supplement intake. And this is corroborated by American Botanical Council data, which says that the first time in the history, the global sales of herbal supplements clocked more than 10 billion. So, and this was replicated in the national advisory guidelines that were issued by the Ayush Ministry, where from both for asymptomatic as well as mildly symptomatic cases, there were prescriptions for substances which were very regularly used in India, which includes Tinospora cordifolia and Piper longum. And this data is available from the ministry website. So what happened a few months later after this is that we got a hint of the incident cases of liver injury that was occurring primarily to consumption of these cases. And as expected, this was greeted with lots of rebuttal from the alternative medicine community. But as you can see, there was an immediate spike on publications related to this specific herb between 2021 and 2022. So that brings us in this background to the 5 cases that we have. The first thing that I would like you to note, the maximum number of the cases had presented to us during the months of those dreaded months of May to June 2021. They were mostly females, except for one case. They did not have any comorbidities except for diabetes mellitus. None of them had any past hepatic events. For non-hepatic events, only one case had history of extrapulmonary tuberculosis around 2 years back, for which she was cured. The index presentation for all the cases were jaundice. Primarily, it was a non-cholestatic jaundice, and only in a single case there was evidence of some degree of pruritus suggestive of cholestasis. There was no features of fever, rashes, or arthralgia, and sequentially, this was limited to development of jaundice, and except in one case, which was the third case, in which there was development of ascites and hepatic encephalopathy. There was no concurrent use of any significant medications except for a short-term use of proton pump inhibitors in the first case and for diabetes use of metformin in the last. So the only commonality between all these cases was an history of consumption of a herb which is commonly used in India, which use had reached exponential proportions during COVID-19. That's Tinospora cordifolia, commonly known as HILI. If you see the time to onset, or the latency period as we call it, was around 10 to 29 days. And the predominant manifestations was jaundice, and except in one case which had gone on to hepatic encephalopathy and ascites. So let's see the labs, how they were. Hematologically, there was presence of some degree of anemia and mild thrombocytopenia. What's important to note out here, that if you see the injury is primarily liver directed, and the signs of liver dysfunction is manifested in raised bilirubin as well as INRs. And if you see the pattern of injury for all these cases, it's a hepatitic pattern of injury. To simply put, a hepatitic pattern of injury is when your ASTs and your ALTs rise out of proportion to your alkaline phosphatase. And conventionally, we use the R score, which is for the ratio score, and it can divide. And if you have it more than 5, it suggests an hepatitic pattern of injury. The second important thing that needs to be noted, that all these patients had positive autoimmune markers to some extent and the other, and they had raised immunoglobulin levels for 3 cases. And as you can see, the degree of liver dysfunction was quite severe. The imaging wise, except for the third case in which the liver was slightly irregular and there was presence of few collaterals suggestive of an underlying possible chronic liver disease, otherwise the liver imaging parameters for all the rest of the cases were normal. So that made us to have a syndromic diagnosis. So the syndromic diagnosis for all the 4 cases is acute liver injury, and for one case, it's acute and chronic liver failure. At this stage, we'd simply like to understand what these 2 entities are. If you have a normal liver, and on top of that, you develop an acute insult, which can be anything, drugs, viruses, alcohol. You develop liver dysfunction, which is manifested as jaundice and coagulopathy. You call it acute liver injury. If this progresses further to develop encephalopathy, you call it acute liver failure. The similar scenario, if you extrapolate it to somebody who's having a fibrotic liver or a cirrhotic liver, there you develop complications of liver failure, that's ascites and encephalopathy, and that you resort to calling as acute and chronic liver failure. This is a very simplistic classification, and the data and literature about acute liver failure and acute and chronic liver failure is quite robust. However, this entity of acute liver injury has not been described in that great details. if you see the natural history which has been reported in a single study till now, taking into account for paracetamol and non-paracetamol cases, the most common causes of acute liver injury reported are autoimmune hepatitis, indeterminate hepatitis, hepatitis A, drug-induced liver injury, and ischemia. And this has a substantial degree of mortality with about 41% progression to acute liver failure, death, or requirement of liver transplant. So let's come back to the cases that we had. So we had a group of patients who presented to us with liver dysfunction. They had a definite consumption of a drug, which is known to cause potential hepatotoxicity. But along with that, there was positivity for autoimmune markers. So there can be three different phenotypes that you can imagine about. That this was possibly autoimmune hepatitis and the drug was just a coincidence, or it was just a drug and your autoimmune markers, as it can be in general population, positive around 20 to 30% of the cases as an innocent bystander, or is there a possibility that there's an overlap of these phenotype, which we call as autoimmune hepatitis HILI overlap phenotype? So on the basis of history, can we distinguish really between these two? Both are female predominant. Acute onset is more common with drugs, but it can again happen in 30% cases of autoimmune hepatitis. If you get fever, rash, eosinophilia, that points towards a drug-induced injury, but that's seen in only 30% of the cases. Concurrent autoimmune diseases would make you more towards an AIH, but the only real indicator is if you have presence of cirrhosis, that might indicate that there is presence of autoimmune hepatitis. So the next step in the protocol normally is to go ahead with the biopsy. But as a clinician, prior to you undertaking a biopsy, we have to think, what do we get in the biopsy that will change our management? Herein starts the big differentials of autoimmune and autoimmune DILI. And if you see in this, there's not much in the biopsy which helps you to differentiate, except if you do get presence of cirrhosis, which would indicate that this is a chronic process occurring from a long time, leading to an autoimmune etiology. So with this, I would invite Dr. Neha from Department of Pathology to discuss the histopathology findings.
So for the first three cases, the case number 1, 2, and 4, we received the linear course of liver biopsy, and the biopsy showed maintained lobular architecture. Here is the portal and the periportal fibrosis. No significant fibrosis is noted. In the case 4, there is a portal and periportal fibrosis with presence of occasional thin fibrous septa. The portal tracts are expanded by the moderate mononuclear inflammatory infiltrates and interface hepatitis. This is the portal tract, which is expanded by the moderate mononuclear inflammatory cells, chiefly with the presence of few eosinophils and polymorphs. Along with the interface hepatitis, there is a cholestasis noted, which is ductal as well as canalicular. If you see, this is the canaliculi surrounded by the hepatocytes, and cholestasis is present. Now, this is a hyper view showing the mixed inflammatory infiltrate. These are the mononuclear cells, plasma cells, and few neutrophils. These are the hepatocytes, which are showing ballooning degeneration, which is a degenerative change, and focal pseudoacinar transformation. This is an oil immersion view showing significant number of plasma cells. These all are the plasma cells, and polymorphs and eosinophils are also there. This is again a significant number of acinar plasma cells are present. At places, the pseudoacinar transformation is noted, which is better appreciated in the reticulin stain. Here is the pseudoacinar transformation. And occasional emperipolysis, which is the engulfment of the mature lymphocyte by the hepatocytes, is also there. So the liver biopsy is showing the hepatitic cholestatic pattern of injury and suggestive of drug-induced autoimmune hepatitis. For the last case, we received a linear course of liver biopsy showing maintained lobular architecture. No significant fibrosis is noted. This is the portal tract showing the hepatic artery and accompanying bile duct. This is the portal vein, and the portal tract is expanded by the moderate mixed inflammatory infiltrate. This is again a portal tract showing the mixed inflammatory infiltrate, and the inflammatory cells are spilling into the lobular parenchyma, showing the interface hepatitis. This is again a portal tract showing the moderate mixed inflammatory cells. The portal vein is damaged by the inflammatory cells. And this is the oil immersion view showing the significant number of the eosinophils. These all are the eosinophils marked by the yellow arrow. Along with that, there are fair number of neutrophils are also there. Now this photomicrograph is showing the portal tract. This is the portal tract and the central vein. And in between the lobular parenchyma is showing the presence of inflammatory cell infiltrate, which is damaging the central vein as well as the perivenular hepatocytes. This is again a foci showing the lobular inflammation and acidophilic bodies. So this is again showing the hepatitic pattern of injury. There is no presence of any cholestatic feature suggestive of drug-induced liver injury. So the differentiating the entities based on the histological features are a bit difficult, as no feature is absolutely indicative of any entity like autoimmune hepatitis, drug-induced liver injury, or drug-induced autoimmune hepatitis. However, the severe portal inflammation, predominant portal plasma cells, rosette formation, interphase hepatitis, and emperipolysis is more consistent with the autoimmune hepatitis. In drug-induced liver injury, the portal infiltrate are of mixed type, and there will be presence of the perivenulitis or central vein inflammatory infiltrate. In drug-induced autoimmune hepatitis, features of both autoimmune hepatitis and drug-induced liver injury will be there. So, however, along with the mixed inflammatory cells, there will be a significant number of plasma cells in the portal tract. Cholestasis may or may not be present, and there will be absence of significant level of fibrosis in drug-induced liver injury and drug-induced autoimmune hepatitis. So combining the features, we can suggest the entity, the drug-induced liver injury or drug-induced autoimmune hepatitis.
Thank you, Dr. Neha. So as we had expected, the margins and edges are not very clear. So what is the protocol that you follow when you're faced with such a case, when you're suspecting a possibility of both an autoimmune hepatitis as well as drug-induced liver injury? So the way to go about it is that you stop the potential agent and you wait for spontaneous recovery. If there is no spontaneous recovery, or if there is presence of any worsening laboratory parameters, or there is evidence of hepatic failure, then you start off with steroids at a dose of 0.5 to 1 milligram per kg of prednisolone, and you assess for response. If there is no response, both your diagnoses were wrong, and think about something else. If you get response, then you continue these steroids and agents for about 3 to 6 months. Controversy exists whether during this time period you add on an additional agent with steroids or not, and you wait and taper both the agents. And after tapering, you consider for withdrawal. If after withdrawal you have a relapse, then it was AIH to begin with. If there is no relapse, after continuous monitoring, there's DILI. A small concern out here that in very, very rare cases, there is reports of relapse even occurring after stopping in cases of DILI. So that's the way we followed in our cases. As we remember, go back to the syndromic diagnosis. If you see the assessment severity scores after biopsy, the score for RUCAM is for the HILI differentials. You see all these cases fall into a probable herbal induced liver injury. And similarly, they also fit into a phenotype of autoimmune hepatitis. So these were treated with prednisolone followed by, in the first case, azathioprine. She developed some toxicity with AZA. We switched her to MMF. The second case responded exquisitely with azathioprine. The third case was sick. So we started her on IV steroids. She developed in-hospital sepsis. We had to adjust with antifungals and the steroid dose. And there was quite a delayed introduction of azathioprine, following which there was complete remission. The fourth case again responded exquisitely to standard immunosuppression. The last case is in the biopsy, as was shown, that there was no evidence of any autoimmune hepatitis. So this was classical herb-induced liver injury. And we treated her with N-acetylcysteine that led to spontaneous recovery. So these are the trends of all the cases. If you see, except for one case which had developed in-hospital sepsis, there was exquisite recovery with initiation of immunosuppression. So what were the outcomes for these cases? Case 1 recovered. We gave her immunosuppression for 5 months. Currently, she's off immunosuppression and she has been so for 3 months. So that confirms your diagnosis. This was possibly drug-induced AIH with the point that we need to follow up further. Second case, also she's off immunosuppression now for 2 months. The third case had an adverse outcome, which was due to cerebrovascular accident. Fourth case is rather interesting. She has also been off on immunosuppression now for 9 months. There's absolute response. LFTs are normal. Everything has been normalized, but she fails to, she doesn't agree to take her off immunosuppression. And this is one of the other nuances of treating such cases, that your discussion with the patient has to be very close, because these patients have experienced a near-death experience. And if they do not want to go off, then possibly you have to consider for long-term and keep on recounseling them. And similar recovery was noted in the fifth case. So that brings us to our axis of discussion. We'll have an overview of HILI, and for a specific aspect of Herbals induced liver injury, let's try to address 6 questions and support it with data. The 6 questions are: is there an increase in use of HDS? And if there is a increase in the use, do we have a concomitant rise in the incidence of HILI? And if there is a rise in HILI, what's causing it globally? What's causing it in India? And what's the story with this specific herb, Tinospora? And if it does cause HILI, what is it a cause of an autoimmune HILI phenotype? So having an overview of herb-induced liver injury, these can be of 2 types. It's intrinsic or idiosyncratic. Intrinsic means that you know that these drugs have potential hepatotoxic agents. Idiosyncratic, you cannot predict such cases, and mostly these cause liver injury by immunologic mechanisms. The key factors, the host factors that are associated with injury is age, that is elderly age with a mean age of around 50 years, and female sex. What's important is to understand the structure, the chemical structure of these agents, what its adjuncts are, how is it prepared, what duration was it consumed for, and what was the amount that it was taken. Additionally, there are other things that you need to consider is alcohol intake, other concomitant drugs, which can be of medicine drugs also, as well as most of these herbal preparations comes in mixtures. There are lots of additive compounds that are added into it, and you may need to individually analyze each of these entities. So this is how you make a simplified approach towards diagnosis. You take any patient who has got laboratory evidence of liver injury, you assess the injury pattern, as we said, by the R factor, and then you exclude the common causes. You exclude the typical viruses, you exclude alcohol, autoimmune causes, shock, conventional drug injury, biliary tract disorders, metabolic and inherited disorders, as well as atypical viruses like Epstein-Barr virus, cytomegalovirus, and herpes simplex virus. Then you assess the causality scores, that's RUCAM, and there is a modified version of RUCAM which is specific for HILI. And after that, you can decide whether this particular herb is actually responsible for the injury. But that doesn't stop it out there. You should perhaps supplement this data with toxicological analysis if you have the facilities, and always go back to the patient to reassess the history and reassess the temporality. The biggest concern with herbs and drug-induced liver injury is that these patients often do not come out very spontaneously with the history. When they report to you, they're many times scared to even mention that what drugs they have taken. So you need to repeatedly go back to the patients and reassess the history. So you have implicated an HDS, but before labeling that particular product is responsible for it, make an effort to look for adulterants, unlabeled ingredients in the package inserts, as well as to look for contaminants. So the first question that we asked was that globally, do we have an increase in the HDS use? On the left-hand side in the upper left, we have data of the areas where you have high usage of these products. And if you can see, the highest usage comes out from China, India, and parts of South America. If you see the global consumption of these drugs, there has been a gradual rise in the US sales from US, and it has now clocked above $8 billion and a projected rise of about $390 billion by 2028. So there's definitely no denying the part that there is a rise in the use of HDS. So HDS use is rising, but do we have data to suggest that due to this increasing use, you have concomitant rise in liver injury? That is supported again by the US DILI network studies, which shows that over the years, you have got an increase in the proportion of drug-induced liver injury due to herbals. And what's more important to note is that the common culprit that was often implicated, that's weight gain supplements, have now been overshadowed by these dietary and herbal supplements. If you see registry data from globally, the maximum incidences of herb-induced liver injury come out of Korea, that's around 70% from registry data, and then followed by China, that's around 33% from the registry data. Unfortunately, from India, we do not have good quality registry data specifically looking at herb-induced liver injury. So if herb-induced liver injury is common, what causes them? If you see the Eastern data, after anti-tubercular drug, today herb-induced liver injury is the second most common implicated agent, the most common in Western data. And you can see all sorts of things that is available. You've got your very commonly used, everyone's favorite green tea out there. You've got Herbalife products where many of us resort to. These are all being implicated in herb-induced liver injury. So if you have such a pattern of herb-induced liver injury, what are the histological phenotypes? And this is where the surprise data comes. This is the largest series of analysis of herb-induced liver injury, and it has been reported that actually the most common feature that you see histologically is a part of immune-mediated hepatitis and autoimmune-like hepatitis, which brings us to the proposition that these herb-induced liver injury and its consumption for immune boosting possibly leads to some degree of tweaking on the immune system and leading to such patterns of injury. So when you have such patterns of AI and HILI, there are 5 different phenotypes that you have to think about. Let's imagine a person who's having autoimmune hepatitis, takes a herb, and on top of that develops that injury. This would look as the same phenotype as somebody who developed an herbals induced autoimmune hepatitis. And then again, there is another possible phenotype in which these drugs cause a liver injury and induce autoantibodies. And rarer phenotype like a chronic herb-induced liver injury, which looks just like AIH with relapsing remitting hepatitis, as well as a very, very rare entity that you take those medications for twice and you have got similar episodes. So what's the Indian experience with herbal-induced liver injury? This is the data from Dr. Abby Phillips from Kochi, which he studied about 94 cases. Why do you take these medications? They are mostly for GI symptoms of dyspepsia and appetite. Multiple medication formulations are taken. The most common pattern is hepatocellular, but as you can see that all sorts of pattern from massive necrosis to submassive necrosis to bridging fibrosis has been reported with consumption of these drugs. And the other thing that needs to be worried about is the presence of heavy metals that have been documented in these injuries. So the substances which have been implicated in herb-induced liver injury from India ranges from ashwagandha to aloe vera to marsh bubbles. And the spectrum of pathology that they can cause, though the hepatocellular pattern of liver injury is the most common, they can cause a wide variety of liver injury, ranging from cholestatic HILI to sinusoidal obstruction syndrome to even granulomatous hepatitis. So what's the story with this particular history, this particular history of Tinospora cordophilia? So this is a very commonly used plant with herb and herb products, and this has been used as extracts after boiling, as well as now we have got common formulations that are promoted by pharmaceuticals as the alternative medicine companies. So the ingredients that if you see, or the literature which has done the toxicological analysis of these cases, that these have some alkaloids that are already there when you have an extract from them. And they're used for multiple purposes, and they're being used for ages, for dyspepsia, fever, immune boosting, and anti-aging. A paradoxical event with this is that an alternative subgroup of this species is there, which is Tinospora crispa, which has actually been implicated previously prior to these reports with cordophilia, which was more commonly implicated with hepatotoxicity. So the initial reports of Tinospora cordophilia associated liver injury was the first case was reported in early 2021 from a South Asian female, but this was in in the United States. She had a hepatocellular pattern of injury, weak positive SMA, and spontaneous normalization. The first case series which brought about all the controversy was from Mumbai, was for 6 cases, and there was a editorialist adjudication with this, where 3 experts from the world reassessed these cases and classified them as highly likely, probable, and possible in each of the 6 cases. So at the same time, we also published our case series from SGPGI, and we also suggested that what are the possible mechanisms that can be there, which are responsible for this. We have to understand one thing, that this herbal product has been promoted as an immune booster. So possibly, and literature also suggests that there is some data about B cell activation, macrophage activation, and overall alteration of the tolerogenic responses that have been reported with consumption of DILI. And that is that has already been reported in details in Ayurveda literature also. So, but all these reports were put up with a lot of controversy and a lot of counterpoint from alternative medicine practitioners, who countered the questions with saying that many patients had comorbid states. You had preclinical safety data that is there with Giloy on Wistar rats, and why was there a lack of chemical analysis in the initial cases? So as this debate ranged on, just last month, around 15 to 20 days back, we had this large publication coming out of 13 centers from India, 9 locations spread around northeast, west, and south, which assessed around 43 cases of Giloy-induced liver injury. And if you see the spectrum, it's very similar to the spectrum that we reported. And this study also confirmed to the part that autoimmune-like hepatitic illness is possibly the commonest feature that you have with it. To support the toxicological analysis, this group also supported it with the data on toxicology, and there was indeed reported concentrations of lead, arsenic, mercury, and cadmium, as well as multiple volatile organic compounds in all this preparation. However, there's one thing that we need to remember is that whether the concentrations that was reported, whether these are truly hepatotoxic, and whether such constituents can induce an autoimmune injury is something the debate would still range on. So the dust has still not settled. The Achilles heel of DILI always remain that, is it just a coincidence or is it just an association? The challenge in DILI overall, and HILI more specifically, is to ascertain causality. How do we go ahead in ascertaining causality? We need better data with plausible immunological mechanisms. Meticulous history and temporality are perhaps the 2 most important things that leads to a definitive diagnosis. Further studies need to be done with corroborative chemical analysis, and not only chemical analysis, to prove whether those chemical constituents can actually corroborate with the type of injury that is being presented. But one thing that we have to accept is that the regulation and monitoring for herbals and herbal products is not as stringent as it is for modern day medicine. And there is indeed need for improvement of regulation and monitoring purposes. But it's not a point of conflict between different systems of medicine. It is to address a challenge where you have a possible entity which is common, to address it with science in unison and not in conflicts. So we come back to what we started with, the elephant in the room, is that there is no point in denying the fact that herb-induced liver injury is on the growth. And also, there is no point in having a silence on the regulatory and monitoring mechanisms. We have to accept that multiple phenotypes of HILI does exist, and autoimmune HILI is possibly the most challenging of all the phenotypes. We need a collaborative effort from all systems of medicine to first identify and prove safety, and then go ahead to establish efficacy. For all who are interested in drug-induced liver injury as well as herbs-induced liver injury, I suggest this freely available website which gives comprehensive data, livertox.nih.gov. And with that, we end the discussion and open it for the House for comments and discussion. But before ending, we invite you all about 10 days from now on the celebration of the first Foundation Day of Department of Hepatology, moving ahead to a more controversial DILI to a less controversial but more important substance, that's alcohol. Thank you, everyone.